So that's right. I'm about to talk to you about the RD in ADRD, a whirlwind tour through some of the other causes of dementia that affect older individuals primarily. Oh. I'm clicking the arrow and nothing is happening. There we go. So for those that are not familiar with clinical practice as much, quick definition, dementia is cognitive decline that has impaired one's daily activities or resulted in a loss of functioning at work or at home, and it's not due to something that is obvious and reversible in most cases. So it also has a second definition neuropsychologically related to performing worse than typical standard deviation away from age-adjusted averages, but most of the time we consider dementia by the clinical definition. And I want you to notice that dementia is not synonymous with Alzheimer's disease, but rather it is an umbrella term, a descriptor, right, by the definition that covers a lot of different entities. Mild cognitive impairment, by contrast, because I'll be referring to it a few times in this talk, is cognitive decline that has not impaired one's daily activities, and the understanding or the assumption is yet. Although, and this is part of a different talk, at times people can remain in a mild cognitive impairment state for many, many years without progressing. The obligate, scary statistics, right now in the U.S., about 8 million people are living with full-blown dementia. If you add in MCI, the number about doubles, which leads to, in our country of 330-odd millions, about 5% of the population living with some form of cognitive impairment. It is not evenly distributed, as most of us recognize. Dementia grows more common with every passing decade. And that leads to a very significant excess of about 60% of those who, by the time they reach 90 plus, having some form of cognitive impairment. You will see later in this talk that the older you get, the less likely it is that what is afflicting you is exclusively Alzheimer's disease. So the remainder of this talk is going to be focused on some of these other alternatives to Alzheimer's disease in what causes dementia. A relatively recent-ish survey done by Health and Human Services about 8 years ago now shows the following breakdown that you can see in the pie chart of the different causes of Alzheimer's disease across, so this is prevalence across all age groups. And to the left you can see Lewy body disease, FTLD, vascular dementia, and mixed dementias as the things that I will be covering, but even that is not the whole story. There are a number of new emerging, or in the case of our gyrophilic green disease, sort of newly appreciated older pathologic entities that also comprise the totality of dementia. So what do neurodegenerative diseases all have in common? This is probably a little elementary for some of you, but they are all proteinopathies for those who are not as familiar with pathogenesis. So in normal cells, there are many proteins that are doing various homeostatic functions, and unfortunately some of them occasionally with aging will start to change their folding pattern for reasons not yet clear and gain a toxic activity or lose normal function. Disease is triggered because these misfolded proteins start to stick to each other similar to Velcro, and it is hypothesized that in many cases, once they aggregate, accumulate, and exert their toxic effects, they can get passed from one cell to the next, like a prion protein. If that is a term familiar to you, that's the cause of Creutzfeldt-Jakob disease. So the most common reason to have these occur is simply age. And to the right, I guess on your slide, you can see listed 6 of the most common, though that is still not an all-inclusive list, of the proteins in brain that are known to do this. I'm going to transition to the first of the specific diseases. The first one on my list is Lewy body disease. And that is comprised, some definitions here, of 2 related clinical syndromes. One is Parkinson's disease with dementia, and the other is dementia with Lewy bodies. Together, these are referred to as Lewy body dementias. The difference between the first and the second is clinically the order in which the problems occur that manifest in individuals. So Parkinsonism, which are features that look like Parkinson's disease, but is agnostic, that term, to the actual entity of Parkinson's disease. So Parkinsonism occurs first, followed within a year or after a year by dementia. That is PDD. If, on the other hand, the dementia occurs first and the Parkinsonism comes on later, then we refer to that same disease entity as DLB. There is also a new emerging understanding that many people go through a stage of mild cognitive impairment prior to full-blown dementia. And so there is greater and greater clinical acknowledgement of this idea of a prodromal state, just like in Alzheimer's disease, which is now referred to as MCI-DLB or MCI-LB. Pathologically, Lewy body disease is characterized by abnormal accumulation of alpha-synuclein protein, just like in Parkinson's disease. And if you're wondering, alpha-synuclein is a normal neuronal protein. All of these are. In the case of alpha-synuclein, it regulates synaptic vesicle trafficking, and it was discovered in the early 90s. It allowed people to understand that what they had been seeing under the light microscope for many decades, and described first by Frederick Lewy, who, of course, in the manner of male scientists at the time, named this finding after himself. It allowed us to make the understanding that these Lewy bodies were actually comprised of large agglomerated tangled fibrils of alpha-synuclein protein. So Lewy body is a specific disease that can cause dementia. It is a neurodegenerative disorder that, like all of them, causes loss of neurons over time in a highly specific and targeted way that I will describe in a moment. It is associated with alpha-synuclein. It frequently has this transitional state, and when MCI is accompanied by a Lewy body disease biomarker, we then refer to it as MCI due to LBD. And very similarly to Alzheimer's pathology, we now understand that a person can have this kind of alpha-synuclein Lewy body pathology in certain parts of the brain or elsewhere up to 20 years before they develop dementia. So the core clinical features for Lewy body dementia, the dementia is obligatory, and then 2 or more of the additional features of Parkinsonism: visual hallucinations, cognitive fluctuations, which are episodes of greater confusion or decreased level of arousal in individuals, looking at times very abrupt and sudden, at other times emerging much more slowly over minutes to hours. And the 4th one is REM sleep behavior disorder. also known as dream enactment behaviors that occur during dream sleep. So our understanding of why Lewy body disease has some of the clinical characteristics that it does has been greatly influenced and expanded by a realization that the Lewy body pathology starts in different places in the brain. This is a distinct difference from tau pathology in Alzheimer's, which almost invariably starts in the entorhinal cortex. In Lewy body disease, it can start in the brainstem, it can start conversely in limbic cortex, or it can start first in cortical regions. The symptoms that a person with Lewy body or Parkinson's has depends very strongly on where that alpha-synuclein is showing up, and the development of further symptoms is strongly influenced by where the alpha-synuclein spreads to next. So in Parkinson's with dementia, the theory is that the alpha-synuclein starts actually outside of the CNS even, travels up from the gut, this is a theory, not a proven fact, toward and into the brainstem, causing REM sleep behavior disorder, sometimes a decade or more before the remaining symptoms, eventually reaches the midbrain where it begins to create the classic Parkinson's disease symptoms. In those who have DLB, the opposite seems to be true. Alpha-synuclein seems to begin first around the region of the olfactory bulb or the nucleus basalis and the infraorbital region, and spreads further from there, or in the limbic variant, it seems to emerge from the amygdala. So I promise to keep this to under 30 minutes. That's all you get about Lewy body disease. The next RD on my list is frontotemporal lobar degeneration. So that is a pathologic term to be distinguished from clinical terminology in which we refer to the clinical entity as frontotemporal dementia. There are a number of different types, and this whole area of FTLD is very complicated by the fact that every single clinical phenotype has multiple different pathologic etiologies, and a single pathologic etiology can give rise to multiple different clinical phenotypes. So bear with me. FTLD's most typical, most common variant is the behavioral variant, also known by the name Pick's disease. And sometimes there is also motor neuron disease with it, which is called Lou Gehrig's disease, but usually when the two exist together, nowadays we simply call it BVFTD ALS. There are several forms of language-predominant FTD. Whoops. And several additional forms that I will not describe today that are predominantly subcortical or a mixture of cortical and subcortical pathology that also fall into this FTLD umbrella and produce primarily or in addition to the cognitive symptoms, motor symptoms as well. These are the three most frequently implicated proteins that give rise to FTLD. And of those three, the first two are by far more common than FUS. Behavioral variant FTD's clinical features are very interesting. It is distinctly different from almost all of the other dementias in that psychiatric and personality type symptoms are often the very first finding and can happen some years before the onset of objective cognitive decline. The cognitive problems that people with early stage BVFTD have are predominantly related to their altered interpersonal dynamics and their difficulty with managing their mood and emotional regulation. Here is a brief story of a typical patient with BVFTD, a 62-year-old financial planner who became progressively more aloof, exhibiting increased insensitivity to others. On one occasion, he abandoned his 2 3-year-old grandchildren at night a block from their house, believing they could return home on their own the rest of the way. A couple of years later, he started to behave in a sexually inappropriate manner toward different women, to eat voraciously, subsisting predominantly on junk food and ice cream. He began to drink heavily and to misuse diazepam, which is Valium. On several occasions, even after being explicitly told not to do so, he entered the neighbor's garage and took liquor when the family refused to buy more for him. The patient seemed to lack insight into how inappropriate that was. Interestingly, or characteristically, standard neuropsychological test scores, even at that later stage, were within the average range, apart from some very mild impairments in word generation and a complex executive task. Despite his quite preserved cognitive skills, his emotion recognition for faces and voices was impaired, as was his ability to detect sarcasm and deception. And if you asked anyone around him if he had cognitive impairment, they would all say, "Oh, hell yes," even though he tests normally, or almost normally. So that is BVFTD. The language predominant forms of FTD look rather different. There's 2 that I'm going to highlight. The progressive non-fluent or logopenic, which is fluent aphasic variance, aphasia meaning trouble with language. In the non-fluent version, there is a progressive loss of speech output. These people start to look like they have had a stroke in Broca's area. Conversely, the logopenic patients start to have emptier and emptier conversation. They can talk for half an hour, and somehow you're still left wondering what the heck it is they're trying to tell you. The semantic dementia form looks rather different. Pathologically, the pathology is far further back in the brain. Rather than being very anterior temporal or anterior prefrontal, in semantic dementia, there's considerable inferior, posterior temporal, and even some parietal region involvement. And these people lose understanding of the meaning of words. So they might look superficially like they have an aphasia, but in fact, if you challenge them by showing them pictures of things, they can't even tell you what they're for. The age of onset for all of the forms of FTD that I've outlined so far is about a decade younger than for Alzheimer's disease typically. So in the early to mid-60s rather than in early to mid-70s. However, the semantic dementia subtype does have a slightly older age of onset. How we diagnose this entity these days is still the way I was taught to do it back when I was a fellow. Unfortunately, we still do not have good biomarkers for any of the forms of FTD, though I think some labs are starting to get close to a TDP-43, and we do have some versions of tau biomarkers. They're just not very reliable yet for the tau forms of FTD. So this is how it's diagnosed still. Characteristic frontal and anterior temporal atrophy on MRI, and you do a fluorodeoxyglucose PET, which looks at energetics, and you can see that there's hypometabolism anteriorly. Moving on, vascular dementia is a cognitive loss syndrome attributable to some combination of one or more of the following: either thromboembolic stroke, small vessel lacunar stroke, chronic ischemia with neuronal loss, hemorrhages, both within and outside of the brain. These entities occur in different parts of the vasculature. So typically damage to large or medium vessels produces multi-infarct dementia. Small vessel disease at the level of arterioles and capillaries will produce an entity known as subcortical vascular dementia these days, whereas you can also have mixtures of ischemic and hemorrhagic processes, often referred to as a mixed vascular dementia clinically. The one I personally find the most intriguing and the hardest to distinguish from a neurodegenerative disorder like Alzheimer's disease is this subcortical ischemic vascular dementia. You can see an MRI scan of a person who's clinically got dementia there in the middle. That white stuff is all ischemic damage, areas of astrogliosis where the axons have been severely compromised or are lost. Why does that happen? Because the brain is perfused from the outside in. Not something everybody realizes, though perhaps everyone in this audience does. The point is that the smallest vessels, the ones that are furthest away from the heart and blood flow, are the ones that are deepest inside the brain. And that leaves more distance for pathology to occur. So there are no great criteria still for determining when somebody's scan that looks like this is responsible for the cognitive impairment that you see clinically. And it is certainly still a bit of an art to determine at what point of damage and scarring a person's cognitive decline is legitimately from just this cause or not. Thankfully, we do have Alzheimer's biomarkers now to begin untangling at least a little bit of that question. Features of vascular dementia cognitively look different somewhat from Alzheimer's disease, though at times it can be subtle. These people have much more processing slowing. It's much more effortful for them to focus and pay attention, and their frontal lobes don't work so well, so they have a dysexecutive syndrome, whereas the memory loss that's so flagrant and prominent in Alzheimer's is typically a little less of an issue here. Non-cognitively, vascular dementia also frequently compromises both the limbic system in the sense of depression and mood disturbances, as well as physical processes that work through the internal capsule and descending motor pathways to cause gait and balance impairment, as well as urinary incontinence. Moving to the last topic here that I want to talk about today, I'd like to discuss and describe this emerging idea that many people, especially older people who have dementia, don't have it from a single problem. They have a mixture of pathologies in the brain, and possibly if they had only one of those, they would not have the clinical syndrome of dementia at that point in time, and it is the aggregate accumulated total of multiple pathologies that are creating the clinical dementia syndrome. So this is now a decade old, this study, 233 subjects who all died as they were followed for quite a while in the Vienna Trans-Danube Aging Study, one of many studies in the US and around the world that were looking at aging as a pathologic entity and following people along over time. What they found at autopsy is that while 2/3 had Alzheimer's pathology, you can see the statistics, how many people had only one pathology versus 2, 3, 4, or even 5. And the most significant number here, by far greater than the single pathology, is the dual pathology group at about 1/3 of the total. And you can see almost every combination of these different proteinopathies and vascular process existing in combination. So late life cognitive decline, this is kind of a summary slide, is now more and more understood to be comprised of multiple different contributors. And people are starting to try to understand what the relationship is between those pathologic entities and not only the emergence of decline, cognitive impairment, but also the speed, the rapidity with which people change. So this sort of spaghetti plot here shows a series of individuals, each of whom have their degree of cognitive impairment on the y-axis and the time before death on the x-axis. And while the overall average speed of cognitive decline is that thick black line, you can see how very variable the rate of decline is. And when doing regression, they found that about 40% of the difference in these cognitive trajectories over time could be accounted for by the degree and the amount of each of these pathologic entities kind of in linear combination. This study did not look at TDP-43. It is possible that this 59% unaccounted for number would be substantially lower, though probably not zero, if TDP-43 were also added to the analysis. So just about my final slide, this slide tries to highlight the strong relationship of age to the non-Alzheimer's pathologies. So the sort of old school belief was that Alzheimer's increased fairly linearly as people got older. I heard many Alzheimer's researchers make the claim 20 years ago that if you live to be 110, everybody would have Alzheimer's disease. This was proven to be untrue by the death of a woman some years ago at age 114 who, upon autopsy, was found to have no Alzheimer's pathology of any extent in her brain. But what we now understand is that these additional co-pathologies, especially vascular damage, seem to come on more strongly with age. And while Alzheimer's disease pathology peaks in one's 80s, things like TDP-43 and vascular pathology continue to climb, so that as people die of other causes, a greater and greater percentage of the total turns out to be from non-Alzheimer's pathology the older you get. So these two pie charts show two groups of individuals from the same study. One group are not demented, the other group are demented. And then there is an evaluation of Alzheimer's pathology and other co-pathologies, and you can see that with regard to Alzheimer's, it is a 50-50 split, basically, as to whether you do or do not have that single entity in the non-demented group. And while there is a slight preponderance of AD pathology over not in the demented group, a very significant minority, close to half, don't. So my punchline and the takeaway I'd like for everyone to go home with is that dementia doesn't mean Alzheimer's disease only and specifically. Clinical symptoms map less well onto brain disorders than most textbooks and neurologists like to admit. Alzheimer's frequently coexists with additional pathologies that are sufficient to cause dementia in and of themselves, and without furthering our scientific knowledge, I would posit to you that in some cases it is impossible to know whether that person's dementia is from their AD or not, their AD pathology. And Alzheimer's pathology alone is often insufficient to cause dementia during a person's life. Accurately diagnosing individuals with full-blown dementia is hard enough, so diagnostic uncertainty increases substantially in the MCI stage. So where I go with this is that biomarkers are going to be at least a partial answer to solving this conundrum of what's causing what. New blood, spinal fluid, and skin tests are helping in that. I am, with that, concluding and happy to take any questions, or please go and enjoy yourselves at the reception. Thank you.